Hey people, how you doing? Welcome to the Sports Therapy Association podcast. You are listening to the dulcet tones of Matt Phillips, Creative Run Chat Live, because we do go out live. And if you are listening to the podcast, thank you very much for tuning in. But if you'd like to join us live and have the joy of being to ask our guests questions directly, then all you got to do is go along to the Sports Therapy Association YouTube channel on a Tuesday at 8 o'clock, and that's how you join us. You don't have to be an STA member. And it's a great chance to hang out, network, to spend some time with fellow soft tissue therapists, and maybe find some people in your area and network that way. If you do decide to join us live and you ask a question or make a comment, then I can bring your comment up onto the screen. For example, very excited Glenn Murphy is first through the door this week, and he's gone, let's get ready to rumble. He's actually put rubble, but Glenn's fingers, it's his age, I think it's a little bit of arthritis or something. But you get the idea. You can type it. And you can also get your logo up there. So we've talked about this a little bit before. Why not just get your Facebook logo and your business logo up there so all the people who listen and watch the show can see that. Sarah Jones is through the door. How are you doing, Sarah? Sarah says, good evening. Gary Benson, the founder of the STA, is in the chat as well. So if you have got any questions which you want to talk on the side to Gary, then use this time now to fire some questions his way. And more people are coming in. So that's how it rolls. It's always on Tuesday, 8 o'clock at the Sports Therapy Association channel. So last week, before I bring up tonight's guests, last week, just to mention, we started the countdown to Therapy Expo 2023, which some of you who are listening might not be familiar with. You might not know. It's a massive big show. I think it's the 11th year now, and it's at the Birmingham NEC this year on Wednesday, November 22nd and Thursday, 23rd. It started off in Manchester a couple of times, then it moved to Birmingham. And the STA has been there every single year in some form or capacity. And for the last few years, we've had the STA Update Theatre within Therapy Expo, which is a theatre within the actual conference. And we have our own speaks and presentations. Normally, people have been guests on the podcast. We managed to nick them for a while from the other theatres in there, and they come and speak for us. And we got a even fantastic, I mean, every year I say it's always incredible, but it's bigger and better than ever. 2 days of practical presentations and theory presentations from what truly are world-class speakers. So if you're interested in hearing about Therapy Expo and indeed hearing about the lineup for this year in the STA Update Theatre, then check out episode 164 on all good podcast apps. And also if you want to watch it, just go to YouTube, or you can go to the STA.co.uk. I was joined by Gary Benson, founder of the STA, Fiona M.W. Higgs, who's the host of the Women in Sports Therapy podcast, and also Tim Allardyce, creator of Rehab My Patient. There we go. Right, so that brings us to tonight. Very excited tonight to have... I want to start by saying, two of the most professional... but I've just had a chat with them 10 minutes off air, and obviously they're just humans as well, but they're fantastic educators. I'm not putting them down at all. It's just lovely people and wonderful, massive names in the industry. They're both called Claire, which is fantastic. It's going to make my job very easy to not sound like a schoolmaster calling them out by their surnames. But we're going to be joined by Dr. Claire Minshull, who's been on the show numerous times. A lot of you from the STA will know Claire's wonderful courses through Get Back to Sport. And joining Claire Minshull is Claire Robertson, who's also been on the show. Some of you will know Claire as Claire Patella, not her real name. We'll talk about that later on. And Claire as well is a massive wealth of information, obviously to do with patellas, which is tonight's subject in the patellofemoral joint from pain to performance. And the great thing is these two wonderful educators have got together to deliver a new course, which is called the Patellofemoral Joint from Pain to Performance, the complete guide to PFG rehabilitation. And we're going to be talking about that and the content and what brought these two fantastic people together. As always, if you guys have got questions in the live lounge, and just fire them away. We're quite happy to answer your questions. Anything you're thinking, anything you want to know, just put them in the comments and we'll bring them up. But I think that is a long enough introduction. So without any further ado, I shall bring up Dr. Claire Minshull and Claire Robertson. Hello, how are you doing? Claire Minshull and Claire Robertson.
No.
I'm so sorry, I couldn't help but stumble before I said the word professional, which is terrible of me.
What are you laughing about?
I know, noted.
I'm sorry, I actually blushed. If I was listening to the podcast, I have gone red because you're massively professional. It's just you're such nice, relaxed humans as well. And sometimes in the academia world, as you well know, it doesn't always happen. Sometimes you get people a little bit snotty and But you guys are not at all. You're totally salt of the earth. Absolutely. Is that fair enough?
I think is that the brand, Claire? Not totally, not snotty.
Yes, that'll be on the t-shirt.
There you go. Another acronym, TNS. Fantastic. Right. So thank you very much, first of all, for giving up your time. Really appreciate it.
Pleasure.
I've mentioned the course that you two are offering. We should point out now that, I mean, this is great news for you guys. The course, this is the first course I think you put together for St Mary's University, Twickenham. This particular course sold out.
Yeah. 50 places gone, 2 weeks.
How do you feel?
We're thrilled.
Yeah, really pleased.
You guys are probably used to it. I mean, you're no stranger to the game, are you? You've been, doing this for a long time.
Well, I think as well, you think it's a great idea, but the proof's in the pudding, isn't it? Yeah, we've got this great idea, and then it's like silence. So it's quite validating.
That's good.
Not just us.
That's good. And we've talked about imposter syndrome a lot, and I think as someone who puts on courses as well, you're never 100% sure, are you, that it's going to feel. You always kind of click that button. Yep, it's live in Eventbrite. Let's see. Day 1, day 2. Oh my God, day 3. Going to have to cancel it.
Yeah. So. And also as well, it's like what you see as, I suppose, in your niche and things that you feel like can be done better. Not that there's a criticism that comes with that, but I want to facilitate and help. But maybe people who you're aiming that at just are not tuned into that at all. So rather than it being a rubbish idea, maybe it's a decent idea, but nobody wants it as well. So yeah, so we're really thrilled. Yeah, we're really excited for it.
Yeah.
Excellent. Right. So, I mean, I just want to get straight in and hear about the course. But as we talked about a little bit off air, I mean, I know you guys really well. And I mean, we were just saying that Claire Robertson, you were at Therapy Expo back in the beginning, weren't you? Kind of like 2014, 2015, back in the olden days. I know. And Claire Minshull, I think have you been there every single year from the beginning, or pretty much?
No, I think just 4 or 5 or something.
Just the last 5 years in a row. Yeah. Okay, that's fair enough. That's fair enough. But yeah, so I've known you for ages, but I'm hoping that the people listening to the podcast, it's really important that they don't know you. Otherwise, all of this is a waste of time. We're just kind of blowing air in an echo chamber. So maybe, Claire Minshull, if we could start with you, a little bit of an elevator pitch of who you are and how Get Back to Sport happened. 60 seconds. Go.
Go. I'm rubbish at this. So I'm Claire Minshull. So I'm a former academic.
50 seconds left.
Oh, right. Okay. I'm a former academic, background in sports medicine and health, but latterly in more health-related populations, a real passion for osteoarthritis and actually delivering decent exercise interventions as a part of rehabilitation to all populations. So the approach might be elite, but the individual also deserves it who's not an athlete. So that's what really spurred me to set up Get Back to Sport. It was originally called Get Back to Sport because that's what everybody was asking me how to do. But it's a wider remit to health and all conditions, really, MSK conditions. So people generally understand it as strength and conditioning. I'm a neuromuscular physiologist, actually, but it's more translatable into strength and conditioning. So it's integrating that by means of teachings, courses, that kind of thing into kind of rehabilitation setting and bridging that gap. But there's a gaping cavern still. It's getting a bit better between clinical and healthy, but the approach shouldn't be different. We've still got the same musculoskeletal systems, neuromuscular systems. It's just that the therapists have got a harder job in that you've got pain and kind of buying all these other things to deal with. But the approach, just because somebody is a patient who is in pain, we shouldn't give substandard exercise prescriptions. So yeah, Get Back to Sport is something that's a vehicle to do that. And I also run Joint Approach as well, which is an online multidisciplinary program for the management of osteoarthritic knee pain. So I guess kind of putting my money where my mouth is as well. So slightly longer than a minute, I think, perhaps, but
no, that's fine. No, that's wonderful. It felt like 60 seconds because it's also valid. I mean, I never get tired of recommending you because
I pay you so well.
No, because those monthly feeders coming so regularly. No, because soft tissue therapists, the one thing I think which unites soft tissue therapists is in their training, they're taught all this wonderful manual therapy in different ways, to rub, poke and prod and twist and all these things. But they're very limited when it comes to what about if we actually want to load somebody instead of just kind of up, you know, and so the natural progression for a lot of soft tissue therapists, if you really want to help this person, unless you want to work with a strength and conditioning coach down the road, if you want to, you know, be able to help them as well, you're going to have to get into the kind of the exercise prescription.
Yeah, and it's also bridging the gap as well. We don't want a person to be a patient and then suddenly a non-patient or an athlete, or vice versa. There's that blend that's needed. So, you know, if I can help kind of blur those lines a little in the best possible way, then that's absolutely my pleasure, you know. And I've been so fortunate with my own rehab on far too many injuries and things that I'd wish for. Having that knowledge myself has enabled me to kind of do that a little bit for me. So if I can do that, why can't I? You know, if I share that with individuals that are making a big difference and more people, then yeah, as I said, that's my pleasure.
Amazing. And if people are interested in a chronological look at the history of Claire Minshull's accidents involving various, then just look back at our different episodes, and yeah, there's something there for everyone. Reads like a Jack Reacher novel. Brilliant. I'm glad to see that you're fully functioning and happy now. But yes, yeah, look back at Claire's been on the show probably 3 times, and each time I think it's coincided with some kind of near fatal accident. So yeah, it's all there. It's all there. But
Claire, feel free to bail now.
Oh my God.
But the important thing is, yeah, everybody who we send your way comes back singing, dancing, and loving it. So you're doing a great job, and really important for soft tissue therapists. And you're going to be at Therapy Expo this year. I'm just going to bring this up on the screen for people who love this sort of information. So I think this is the latest information. So there's going to be a couple of sessions which are going to be in Theatre C on day 2, which is the Thursday. So if you're listening and going to Therapy Expo or thinking about it, and you're interested in the S&C side of things, then Claire is going to be delivering the first one. I've got down as 11:30 on day 2, how to optimize rehabilitation for the OA knee, osteoarthritic knee, stronger muscles and a stronger mind. And then at 2:45 in the afternoon, how to properly use your handheld dynamometer to generate meaningful results, which is something we were talking about actually just a few weeks ago with Keith Burnett in episode 61. Right. We were singing the praises of just having a dynamometr, and they don't have to cost much.
Great. It's great having a tool. I'm such a geek when it comes to assessment and dynamometry. And my PhD viva, I was examined by a biostatistician, which wasn't a good idea to say yes to. But it's so important. You can have figures, but if you don't know you don't know what level of confidence you've got in those figures, it's they're arbitrary. So you know it's a really, really important point that goes alongside assessment. So if those assessments are meaningful, then it can help shape your rehabilitation. You know, help you make decisions. But if you've got such vast variability associated with that measurement, then if you do use it, then worst case scenario, you're doing the kind of making wrong decisions. Worst case, it means nothing. So yeah, some good simple things you can do to even help improve those measurements.
That's going to be such a valuable one to go to. I'm going to say that for so many people, but that's the first time I've said it actually. But that's so important because it doesn't have. Therapists spend so much money sometimes, so much money on stuff, and the handheld one hasn't got to cost a fortune. We're talking through with Keith, and it'll help your career because then you can give tangible results to the coach or the manager who wants to see, well, why is your screening helping, or why have I got to spend 8 weeks on this week? What's getting better? And there you go. Look at the strength here. Look how the strength correlates with that. And it's like, okay, I'll give you some more money then. Otherwise, he's getting better. Oh, really? Okay. Yeah. It's not really going to really cut it. It's going to be a great talk.
Really important. And here's the thing. So why do you have to take 3 measurements rather than 1? And the level of precision that's required with intra-individual assessments versus a group, which again is another addition that therapists kind of need to think about if they're going to use those for feeding back. So anyway, I digress. I might stop talking about that. Sorry, guys.
No, it's great. But really good. And fantastic. Right. I've left Claire. Well, please still here, Robertson. Right, so there's our warm-up. That's the warm-up act. Now we move over to the heavy academia of it. Claire Robertson. Sorry to leave you for so long.
That's all right. I was just listening and enjoying it.
So same thing for you, if you'd be so kind. Let the listeners have a brief history of how you became Claire Patella. There we go.
So, I'm a consultant physiotherapist in patellofemoral pain, and for about the last 20 years, actually, I have had a sort of triangulated career between second opinion patellofemoral patients, research, and teaching. And my teaching nowadays is all housed sort of excuse me, through Claire Patella, which is my my business. So and it came about because it's quite funny, I don't know if you know this story, Matt, how it came about over the Claire Patella thing. I was presenting at NEC primary care conference ages ago. Twitter had just been born pretty much, and someone said, you've got to have a Twitter account. And I said, oh, what am I going to call it? And I said, oh, I'll just call it Claire Patella.
Brilliant.
So that's what it does on the tin.
Yeah.
That's how the Claire Patella thing was.
That was 2013, because I did look at your Twitter. I saw Claire Minshull first of all and thought, wow, you've been on Twitter since 2012.
I have.
You have. I thought that is a long time, you know. And then I thought, for example, let's look at Claire Robertson, 2013. It's like the year after. So, but isn't that incredible how long Twitter's been around for? It was a big year, 2012, 2013. That was the first Therapy Expos. And that's when suddenly we all jumped on it.
Exactly. So, but yeah, so my big passions are around making both my teaching and my research meaningful to clinicians. So all my research is driven by things I see again and again and again, like my crepitus research, thinking, what's going on here? Why has no one looked at this? This needs to be looked at. And then my teaching, it's very important for me. It can't just be interesting, it's got to be useful. So I want to empower people. I want to leave feeling I can do this. I don't want to be seen as the big guru and make them feel, oh gosh, you know, I can never be like that. I just want people to think, yeah, I can do this. I understand this. I can't wait to see my next patient with patellofemoral pain. So that's sort of the driver, really. And I think Claire and I share a lot of that mindset together, which was, you know, one of the reasons why we came together, really, because we realized we were really on the same page.
Yeah, I can hear that totally listening to you. Things like taking kind of the research and putting it into clinical practice. That's I think one of the many factors I think which brought you two together. And and why your courses are so successful, I think, because it's exactly what it does. It does, because it can be scary, can it? People kind of run away a little bit if there's talk about academia and research and, oh, where do I find these papers, and I can't get full access and all that, and they kind of avoid it, and it shouldn't be that way. It's just sometimes it's presented in a little bit of a snotty way. So excellent. And ClairePatella.com is your website. I'll just bring it up for people on YouTube so you can see that. I think do that. There we go. And again, there's courses on there and blogs and a lot of information. And also what I mentioned, or what we talked about off air, you're still doing your pick of the bunch, talking about kind of what's out there. Talk us through that. So
people can just sign up to that on the website, and it's free, and I simply highlight what are the 3 papers from the last quarter that I think are most useful for clinicians to be aware of. So, you know, it's not going to be anything that's just sort of lab-based and it's impossible to see how you can integrate that into clinical practice. It's all about what can I read and go, right, yeah, okay, that's useful. I can apply that.
Fantastic. Which is really refreshing, because the trend these days with papers released is to kind of put it up in a TikTok video and slag it off for 5 minutes whilst you're sitting there making funny faces and ridicule something that you were saying 5 years ago as if you never said it. So it's not mentioning any names, but it's really refreshing to see somebody who's actually being proactive and saying, look, these 3 things have come out and this is what we think about it. Is it all to do with patellas, or do you digress?
I will sort of go sideways slightly to the distal ITB.
Oh wow, that's a journey for you. Wow, that must feel really weird.
Or maybe I might go south to the infrapatellar fat pad.
That's south.
I'm feeling brave. But yeah.
So people never know what part of the knee you're going to be talking about.
I know, just get on the edge of their seat. Yeah.
I think in the last chat we had, I think you said the idea of treating someone with the shoulder is just abhorrent to you and scary as hell. You could never move away from the knee now because it's just
God no.
God no. Excellent. Right. Well, thank you for that. All links to websites and things we're talking about will obviously go into the show notes if you're listening to the podcast. Just go to Podbean's probably best, but you can also go to the STA165 and YouTube. I add them eventually. So if you're looking for these links to websites and things, then they will be there. Right then. So this course, we can see why you guys got together. And we can see why it's sold out, but it's a massive topic. You guys are claiming now to provide the complete guide to PFJ rehabilitation.
Yeah,
that's the t-shirt.
Absolutely.
No pressure.
The complete guide.
Complete. You've got to call it something that
of course,
there's a hook. I think obviously it's not going to be the ultimate complete guide, and as we're putting it together, there's so many extra things that we could put in. But what I think it does do is, like you said at the start, it integrates two different types of expertise, but without being disjointed. So with a common theme to looking at the patellofemoral joint, and then thinking specifically about some really detailed things and how we can look at that completely, I suppose would be the better way, and take them from that presentation through to what they want to be doing.
Yeah, and we were really keen that it wasn't sort of, I do the morning, all about the patella, and then Claire does the afternoon, all about exercise. That was like absolutely what we didn't want. So we made sure that the whole day, all the way through, is really integrated and, you know, really pooling that expertise between us.
And that's, you've just answered my question, actually, where it's not just going to be one morning this, one afternoon that, it's putting it all together. So does that suggest that there is a little bit of a gap in the approach which some therapists apply to this knee when they're trying to assess and treat this one side or the other? They're either just thinking about the rehab and they don't know enough about the anatomy and morphology, or do you think there's a gap and that's why you're joining this and trying to present it all together?
You go first if you want on the PFJ specifically.
Well, I think the thing is, I think it's an area that often gets treated quite recipe-like. So a bit of a coverall basis, maybe for giving some glutes, some quads, a bit of stretches, maybe pop an orthotic in their shoe, something might work, happy days. Well, actually, we look at the literature on adherence to exercise and you start going even over 3 exercises, very often adherence will drop off. So that's a major flaw. So then you've got the sort of just can't go wrong getting strong brigade, but actually as much as, you know, we like strength and we're going to talk obviously a lot about strength on the day, we need to also be more sophisticated than that. We need to say, yeah, but what if this person is fearful of exercise? What if this person hears their knee making a funny noise when they're doing their strength exercise? So actually just a blanket, give everybody a load of squats and lunges, that doesn't cut it either. So it's sort of finding our way through and finding those areas that actually really will elevate people, although they're quite simple measures, elevate people in their expertise treating this patient population.
And again, from an exercise perspective, it's, you know, if you're just looking at that as an intervention, you know, what is, you know, if you want somebody to get stronger, we've talked about this so many times on this podcast. If you want to get stronger, what are you going to do with them? How are you going to do it? How much are you going to load them? For how long? Are you thinking about rest? Do you think, you know, if you want to improve speed of muscle activation? So we actually integrate strength and rate of force development and switch on times of muscles, where you've got a need for a strong muscle, but you've also got a need potentially in a different presentation where we might prioritize speed of muscle activation for help rectify an instability a little better. How do you differentiate between the presentation of, you could maybe even do exactly the same exercise, but the way in which you do it be very different to elicit those specific outcomes. And it's optimizing that input-output equation that you're doing with your patient. So what you're doing with your patient is going to have the best effect. And then also what they're doing as a result of your instruction. So the physiologic adaptation as well. Just again, yeah, as opposed to highlight is that nuanced approach, which isn't complicated. Again, just to reiterate what Claire has said, it's not rocket science. It's doing the basic things God, can you imagine me as a rocket scientist? Might make it to Yorkshire. It's doing the basic things, understanding what that is, and doing that effectively. And with the clinical presentation, how you establish that hierarchy of importance of what.
So I'm interested, going back to what you said, Claire, about kind of considering some of the psychosocial factors, if there's kind of kinesphobia or something, or scare of movement. And is this, because there's this idea maybe that if you're dealing with a non-athlete, there's going to be more of that. And then if you're dealing with an elite athlete, there's going to be none of that, and they're all ready to do everything you want. So, I mean, how does it differ? I don't know whether that's right or wrong, and I'm interested to know, but do you cover that sort of differences between the person in front of you, you know, the level of their exercise and knowledge and all that?
Yeah, we're making quite a substantial part of the day case-based. So, and we're looking at really varied cases to help really illustrate these points. But, you know, fear can be present. It's very dangerous to be presumptuous, and fear can be present, of course, in someone sedentary who's never exercised and has the feeling, well, exercise is harmful. But also, actually, we can have fear in our elite athlete whose pain has come on through their training, and therefore they feel, oh my goodness, you know, I'm nervous about going back to it because my pain is improving. I don't want to make it worse again. So, you know, you can have fear, and that's just fear of pain and exercise. There's fear wrapped around crepitus. There's fear about moving in certain ways, doing certain movements like crouching, kneeling. Might be that the fear is of, you know, something more athletic like jumping, but fear can present anywhere. So we're looking at case-based work quite a bit of the day to really explore this.
Excellent. Sounds amazing. And out of interest, what sort of people are you expecting to come along to this? Is it going to be a mix of different disciplines, or who have you advertised it to, or who would benefit from coming to it? And what sort of level of information should they have already?
We've got a range of backgrounds. I think majority of people are physiotherapists. That being said, there are other therapists in there as well. So from your kind of soft tissue therapists, everybody with that interest in rehab, and particularly with the PFJ. Some chiropractors, osteopaths, sports medicine doctors coming along, SEMs. So no pressure, right?
That's lovely as well. I mean, that's amazing. Any event I've gone to, a workshop where there's a multidisciplinary kind of delegates there, that's wonderful as well. It's just a great chance to be able to talk to each other and go, oh, I didn't realize you did that. I didn't realize. But surely you just click bones and you just think, and it's not at all. So that should be amazing.
I think as well at postgraduate teaching, there's such a richness you can get from the room. And, you know, as much as we're sort of giving them a framework, if you like, to apply, I often say you then use your physio toolkit, you know, in terms of how you like to handle or move, perhaps verbal cues that you use, you know. We're not going to say, you must do it exactly like this, because that's disempowering. We're going to say, look, here's the framework. Now go and hang that rich tapestry of experience. And that's the kind of science versus art thing, isn't it? All of these things that bring that artistry in, but just make sure that you're hanging it on a evidence-based, considered backbone, if you like. So I think I like, again, Claire and I have talked about this a lot, about sort of doing group work within the day, tapping into that experience within the room and empowering people. It's really important that they realise how much experience, and, you know, I think 50 delegates, you know, if the mean is 10 years qualified, that's a lot of years of experience in the room.
Yeah, that's really good. Because you think of the traditional kind of guru-led courses, all you're going to do is create these therapists who act like a guru with their patients there, kind of getting rid of all that communication.
That you are a guru.
Yeah. But that now hopefully is being pushed aside now to somebody who's leading it, and they're facilitating them. Well, it's more like led by the delegates, isn't it? What would you do?
I couldn't stand in front of 50 people and say, I'm the font of all knowledge. And like, oh, 2 people even, you know, 1 person. How could I be so arrogant to say that you know, what I know is a lot more and better than you? So as I always said, and I know Claire feels similarly, it's a sharing of what what we've accrued over time through our own personal research, practice, deployment, other teaching experience, and bringing that to a room of individuals that very kindly want to hear about it, that we can share with them. As Claire's saying, you layer that on or weave it into your existing experience and share within the group as well. I always start my courses saying there's a wealth of experience in here. Talk, I don't know everything, definitely don't. So I learn oftentimes as well.
Sounds great. Sounds really good. Let's get into some of the nitty gritty of the actual course. Like what in there? What's it like? Have you either of you got a particular favourite where you think, right, this is going to really be interesting for people? Let's get into this. I mean, I know the whole course is going to be exceptional. Is there a particular part of it where you're looking forward to presenting it because you think that's really going to help people?
Oh, that's a good question.
I know. I should have emailed you that 2 weeks ago.
I'm excited for it all. This is obviously the first run through, and we'll see how it all goes together. The way that which we've planned it is, and I think we've got quite a bit of experience of running courses between us, so I think we're pretty confident how it's going to go. But I'm excited to see the integration of two people's work. I have to say that the facility is second to none. It's just amazing. I might take a sleeping bag, but so yeah, doing some of the exercise interventions, the loading, the differentiating between types of loading and exercise adaptation. So let's not think about deloading as a first strategy if we're presented with pain. For me is exciting, but what's even more exciting is I think I joined the call as Claire was speaking, saying that we've learned from each other. I've learned a lot from Claire, and I'm excited to integrate what I know with her knowledge, such that we can adapt exercise, present it to different presentations, if you like, or different types of patellofemoral pain in different ways, commensurate with the diagnostic skills that Claire's going to facilitate and deliver. So all of it.
All of it. That's a cop out, wasn't it?
Let's
move swiftly over to Claire Robertson.
I'm afraid I'm going to be a bit annoying and say I feel the same, really. And I guess one of the things that I'm really looking forward to is hopefully getting people to move away from this recipe like, right, patellofemoral pain, this and this. And I think that I'm really hoping that by the time we get to the case studies in the afternoon, which we've given a lot of time to, we're going to really see that actually we've got our postpartum mum who's trying to get running again, fit, and she's getting patellofemoral pain. And actually we've got our sort of, trying to think of our cases now, Claire, but our cases.
An older person with that was coming back to activity, didn't we?
That's right. That's right. And someone then that's had low back pain, got over the low back pain, but it's left them with some gluteal strength deficits, and then that's
adolescent really, as well, isn't there? In there,
and then adolescent. So really, I'm looking forward to hopefully really seeing that people that perhaps at the start of the day might have gone, okay, patellofemoral pain, I need to do this, and this, morphing into now I have a way of breaking this down, okay, and I'm more confident to put my cards on the table and just go down this route or go down this route. And yeah, I think for me that's the bit that I'm perhaps really looking forward to.
So that was a good answer. Well, no, we're moving on now. A bit late, sorry, Minshull.
Yeah,
no, go on then.
I think it's drawing on each other's research as well. And when we first got together and started chatting, I found it fascinating to hear some of Claire's research that looks at the morphological characteristics of, in particular, the VMO. So under most circumstances, I often advocate a strength-first approach because that's most often the thing that gets missed, doesn't get rehabbed properly, and also with any degree of inhibition, even just deconditioning because of something else, bed rest, for example, we lose strength really quickly. And if you've got a short period of time, that's something that you can seek to remedy quicker than other things, potentially. But one particular, I'm not going to give the whole game away here, but under some circumstances or one particular presentation, it might be that the hypertrophic intervention, so increasing the muscle cross-sectional area of the knee extensor group, including the VMO, might be the priority under these particular circumstances, which is it's made me rethink things a little bit, or quite a lot, particularly for that presentation. So yeah, I'm quite excited to talk about that.
Excellent. I did have another question there, but you jumped in, but I'm glad.
I'm sorry.
No, that's fine. Talk to me about variance in knees, because I'm interested in that. I think part of your course is looking at kind of variance within the morphology, within the shape, and how much that can change your expectations and your treatment. What sort of, without giving too much of it away, but what are some of the things you look into with regards to that?
Sure. Well, I think you can get a scenario where you get a grossly abnormal knee, and that will start presenting. It's blindingly obvious in a way. You know, age 11, kiddie starts dislocating. So, okay, that's the most extreme. And if we have a spectrum of highly abnormal and abnormal, we've got everything in between. And there's a whole middle ground where their bony shape or their patellar tendon length is, or their quads attachment is not in the, let's say, the sort of perfect size, shape, position. And yes, you can do all sorts of fancy measurements on MRI, but I'm going to very easily show people actually how you can just get a flavor for this with your eyes and your hands and have an assessment of this, because understanding it then can really help you work out, well, actually this person needs this, well, this person needs this. And then Claire can then come in and say, well, okay, so from an exercise perspective, how can we help this person? How can we, optimize our exercise intervention to meet the demands that we've spotted that they've got morphologically? So it's an area that isn't talked about very much, and part of that is the lack of literature on the area. But this is where I think, you have to sort of say, sometimes you've got to look at clinical experience. And I had a milestone recently, Claire, when I'm about to say, and that's that I went past my 10,000th knee patient. And
congratulations.
Seeing his grey hairs. And thing is, though, I'm not going to ignore the pattern recognition from seeing 10,000 patients with patellofemoral pain and seeing these patterns emerging with some of these morphological issues is really powerful to impact on your practice and then make your exercise interventions really effective. So it's making something that sounds really complicated, just saying, look, use these, this is what you can do.
Mm-hmm. Excellent. What else? Keep going. Variance.
So hypermobility, that's something else we'll look at. And there's some nice recent literature that we can pull on as well, looking at strength in patients with hypermobility. Can't say too much.
No, I know. That's fine. I just wanted to get those buzzwords in, like hypermobility and how much does, it's really interesting. There's so much interesting depending what you. There seems to be a change now in the way that people look at stretching. I'm not sure how much is brought about by research or how much we kind of swung the pendulum too far the other way, saying, oh, you don't need to stretch it and blah, blah, blah. But now there's kind of this idea that stretching is itself actually a type of loading. It's still having a similar effect. Have you seen that? I'm interested to know whether that's just a little bit of a thing that's going through Twitter at the moment, or should we be reconsidering, you need to get stronger, not more flexible?
Well, what's the goal of stretching? That's ultimately the question, as with anything, right? So what is it that you want to achieve? What is the deficit or the performance parameter you want to change? I recently have written a couple of blogs on my site about stretching, one of which is provocatively titled, "It's Stretching is a Waste of Time." No, it's not totally. And you're right, stretching can be, so if we're looking at tissue elongation, we're looking at contractile performance. So the worst case scenario, let's say, is that you elongate tissue, but you don't commensurately improve its contractile capability. So you get a greater range of motion, tissue distensibility, but you haven't got the contractile properties to be able to perform at that length. Mm-hmm. A lot of injuries happen at long muscle lengths or extended joint positions, so that's not necessarily a good thing. So what we, if we do want to elongate tissue, we want to increase range, for example, then we'd also want to be able to control that range and also be strong at that range. So we're starting to think about the exercise interventions that can do that. And are we thinking about the muscle tendon? What is it that we're trying to change in terms of morphology? But if we just think about the musculature, let's say eccentric type loading training done intensely enough can bring about a change in the length tension relationship. So you are stronger at longer muscle lengths. And that's good. Okay, potentially if we're thinking about that injury scenario of being potentially injured at longer muscle lengths or extended joint positions. And we could go off on a tangent at that, but come back to your question about stretching. So if we want to increase range, should we do stretching? Well, and you're right, there is research that's showing that actually you can stretch and increase the contractile properties of the musculature. However, the intensity of that stretch needs to be pretty significant. And a paper that I talk about on my blog is that it conveyed, so the stretching intervention compared to a resistance training intervention, they both conveyed some improvements in muscular strength, improvements in the range as well. But the stretching intervention was an hour long, and the stretch was externally applied. So in order to generate enough force through that tissue, it's likely you need external help for that. So you holding, pushing, doing a calf stretch against the wall or kind of sitting on your heels or whatever, that's not going to be sufficient to provoke that loading into the tissue to cause it to adapt. You need that external overload. And to generate, 20% gains in muscular strength, if possible, you might have to commit to an hour 6 times a week of a constant stretch versus maybe, 15 minutes 3 times a week as a strength training intervention. So again, it's bang for your buck or optimizing that input-output equation. So stretching might also have other, obviously, effects. Again, it's coming down to the application and why are you doing it. So I'm not saying stretching is bad per se, but what's the reason? And if it's to improve contractile properties, I think we've got a better way of doing that. If it's acutely post-surgery and you're trying to increase range and think about other ways of distending tissue, then maybe it's slightly safer. But
thank you. Okay, anything you want to add?
Well, I think yes, and I think there's some sort of wild claims, aren't there, around stretching, and I think we're certainly not adding sarcomeres in series. I think we need to think more around tone, and I've actually got some published work on this where we've looked at the angle of the vastus lateralis fibres using ultrasound relative to the femoral axis, and shown that with sort of PNF type stretching, hold relax type stretching, and also the same effect with another arm we did with foam rolling. Those patients or subjects, I should say, that had a large fibre angle to start with. So to contextualise that would be like your classic cyclist with really big VLs that might seem really high tone intense. The patients with that big angle were the ones that had significant change measured from those foam rolling or the PNF type stretching. So intuitively, for me, that fitted with my clinical practice. Those patients that come in and they're so tense and you want to get your hands stuck in, and release that VL and relax the tone. I think we can do that with soft tissue massage. And potentially my work is showing on the VL that we can do that with foam rolling or the PNF type stretching as well. And that is potentially useful for the patellofemoral joint because it means there is less lateralizing force. When you've got a VL that's like that, all of its pull is lateral. Whereas if the tone is reduced, the fibers sit more vertically, then one would like to think that the load is spread more symmetrically, which has got to be a good thing.
Okay, fantastic. Thank you very much. It's 12 minutes to, and I was asked to mention this to you because it's a word that comes up in a lot of training for, well, it's even mentioned in level 3s, which these days is for soft tissue therapists who aren't supposed to work with injured tissue, but they hear it straight away because it's like a flag for, oh, watch out for this. You can do this little mobility test and wiggle their kneecap. Patellomal tracking. Oh, for those who listen to the podcast, we just got a beaming smile from Claire Minshull and a kind of a knowing nod from Claire Robertson. But yeah, it's
So,
still,
So what do you want to know about it?
well, I mean, it's on the one side, it's still being taught as, oh, you're level 4 now, right? Make sure you do this mobility test in the patella, and if there's too much movement there, then that could be what's causing this knee pain. And then you got the other side of the pendulum, people saying it's ridiculous, and the idea of patellomal tracking is just a myth, a misconception. And
to clarify, you mean to identify if the patella might,
if there's too much mobility there, yeah.
Mobilizing the patella in an extended knee position.
Exactly. And then looking at the journey it takes, expecting it once again, the norm is it's going to move nice and smoothly down the center when you kind of put your fingers there. And if you see one which is kind of deviating a little bit to the left or the right and not bang in the middle, then that could be a cause of the pain. So,
well, I think it's when you're looking at patella position in supine, it's one piece of information, and I wouldn't totally discount it, but it's a piece of information amongst many. So, for example, sometimes someone stands up and their patella position is totally different straight away. And then they put a shoe on and it's different again. And then they stand on one leg and it's different again. And then maybe they do a squat and it's different again. So we have to say, you know, how relevant is it where the patella is sitting in supine? I am interested in the amount of passive movement because I'm interested in to know sort of where on that spectrum actually is it hypermobile? Does it feel actually, are they apprehensive? Do they not like that? Okay, so are they actually unstable? Or if it feels hypomobile, I might say, well, what's the other side like? Is this their normal? Or actually, hang on a minute, they're 6 months post ACL reconstruction and their rehab has been going quite well, and then they've developed patellofemoral pain, and hang on, oh, they're telling me they had swelling for quite a long time they found difficult to shift. So, okay, what's the legacy of that swelling? The swelling's gone now, but they've been left with a sort of slightly gummed up patella. So I know that's not a straightforward answer, but it's back to context again and just reasoning it through. What am I feeling? Is it their normal? Is it relevant given their history? What happens when they then move, stand, etc.? Is that okay? Is that really?
That's great. That's wonderful. Yeah, no, that's great. I'm just giving Minshull time to reflect and add.
I like what Claire said.
Yeah.
Good answer.
I think
that's great.
It's illustrating, isn't it, that we have to have this individualized approach, because if we just use, like Claire said before, a recipe, X plus, X equals Y. So you've got a patella that seems to be hypermobile while somebody's got an extended leg. Therefore, we're going to give them these exercises. Maybe it might work in a few cases, but probably not the majority. So it's having that, even just a few extra bits that you can add into that equation to help that with that decision-making process.
I think a lot of the time the idea is if it's moving one way, then the muscle's pulling it that way, and if it's moving the other way, the muscle's pulling it the other way, and then the prescription is quite simply, if it's moving that way, you need to do this to strengthen it. So there's this idea that I'm interested in this. How easy is it to actually direct what quad you're going to be strengthening?
Have you got a muscle stimulator?
Not on me.
Because then you can put that over the VMO, can't you, and externally apply the stimulus.
But I think
so there are different ways of performing the exercise, and you can stimulate more lateral or medial, or
I think we're moving away from that a little bit, really. That if you look at and this is where Claire's research and knowledge exceeds mine, but from what I have read and what I have seen, that I think really, individuals, let's say with patellofemoral pain who've got muscle atrophy, I don't think we see a really big difference between extent of atrophy of VMO versus other quads. And I think some of the more recent studies that are looking at kind of EMG and jump in here if you've read different stuff or you've done different stuff here, that's showing that when we're doing quad-based exercise, that it's really difficult, let's say, to isolate the extensor from the other when we're doing knee or as I say, knee extension work or work that involves the knee extensors eccentrically. There's ways in which you can bias muscle group by positioning, whether that be foot position, hip position, whatever. But I think it's, to try and set out to optimize your prescription to the VMO. I think you'd probably be best investing those efforts kind of elsewhere and maybe go for the whole quad and think about symptom resolution, accommodating symptoms.
Yeah, and I think adding with that, I would sort of look at it the flip way, rather than saying, how can I select the VMO out, is to say, how can I make sure that my exercise prescription doesn't switch the VMO or down-regulate the VMO because of pain, swelling, time of day, angle I'm doing it at, fear, or all of the things that can, and we know the VMO seems to be quite quick to perform poorly, particularly in the presence of pain or swelling. So, I think it's more about making sure that your exercise prescription is such that you're not inadvertently feeding the problem.
Yeah, symptom modification. That was the word I was looking for.
It's getting late.
Sorry. That's the knock on the head.
Well, I was going to say anything, but yeah. Excellent. Yeah. Just I'm not going to let you get away with it completely there, Claire Robertson. So what would you take out the equation to make sure that VMO is being stimulated then? You mentioned there could be afraid or
for example, I'm a big fan of talking to patients about time of day, because often their pain is quite different at different times of day. Okay. Often it can get worse as the day goes on, but when do people tend to do their exercises? When they get in from work or after the school run or whatever at the end of the day. So just saying, well, hang on, actually, your muscle is going to perform better. The muscle trying to get stronger is going to perform better in the absence of pain. Or even if we need to, using analgesia, saying okay, have the analgesia and then do your exercises half an hour later. Or in fact, there was a nice paper by Laura a couple of years ago showing ice before the exercises in the presence of pain and or the swelling can be really effective in improving force generation. So actually just looking at those simple measures, time of day, timing with analgesics, doing it after ice, and then what exercises. I mean, it's interesting running a second opinion service. Patients will often cite they were given squats and lunges because I was told I needed to get stronger, but they really hurt. And then I said, so what did you do? Oh, I just stopped doing them.
I got you. Yeah.
Right. So, just making sure you
engage the VMO, won't it?
Yeah, exactly. Yeah. So moving away from that same old, everyone gets the same program, that sort of generic knee program, saying this patient can tolerate this really well. They're doing that exercise beautifully. This patient, they're really sore with that, and they're particularly sore in the evening. So let me make sure they're doing this earlier in the day and a different exercise.
Brilliant. Excellent. As long as it's not leg extension machine, because they're really bad for you, aren't they? I read the other day.
Shear forces. Oh my God, yeah. Just don't do this. It should be banned.
But then again, it's tricky because we do live in an age where, good, well-meaning therapists look at the internet and there are things which are trying to, say something new and different. So, but yeah, that's broken it down nicely. Thank you, Claire Robertson, for that. That's brilliant. So by finding a way for the patient to be able to do the exercise and not suffer so much in pain, you're more likely to stimulate the weaker muscle.
Yeah, and then let's do it. Yeah. Let's face it, who wants to go and do a painful exercise several times a week?
Excellent. It's 8:57. You've absolutely silenced the room. I mean, people here, apart from the faint noise of pencil lead hitting paper as you're talking. I can't hear anything else from there. So thanks for joining us, people. Thanks for coming and just watching, people in the live lounge.
No questions.
Come
Hope you're all
on,
okay.
that's
There's
all
no
right,
question
then.
there at all. They'll start coming through now. Sorry, taking notes, and there'll be apologies. But anyway, fantastic. So, yeah, 3 minutes, 2 minutes too. So I'm going to have to say thank you very much for joining us. I mean, there's so much there to entice people to do the course, but in my opinion, it's just you're not like you say, you're not rocket scientists. You're conduits giving information that probably the therapist will go, yeah, that makes sense. But it needs people like yourselves to actually, I mean, it's almost as if you're delegates to the patients. You need to get them in the right environment and then share the information and then just let the coin drop, sort of thing. And then they can work out themselves, you know? I
think it's like saying, after saying, look, the dots are all there. I'm just going to help you join them up.
Cool.
Yeah.
It's going to be great.
And yeah, if you have a read on the website as well. So we will be running other dates. So we've got, I mean, honestly, we've been blown away by the interest for this. So many people wanting to run the course as well, and internationally too. And so we absolutely will be running some more of these. So if you wanted information on that, priority information, there is a sign up on the website. So on my website, getbacktosport.com, on the in-person courses, there's the PFJ for pain to performance. Easy for me to say. So whilst it says it's sold out for the particular one in Twickenham, there's a box there to tick and to fill out your name and email address, and we will put you on the list for preferential sign up and information for the next date. So as soon as we've got some more dates, we will let you know.
Amazing. Getbacktosport.com, people. That's the place to show your interest in future courses, and obviously as well head along to clairepatella.com for loads of information there as well. And also I recommend, I'd like to see a spike in the number of people signing up for free to what was it, Claire's Picks? No, that doesn't sound
I'm
right.
signing up.
Pick of the bunch. That was it.
I didn't know that, Claire.
Oh, there we go.
Yeah, I want to see a little spike in that because of people listening to this, because it's just free, great information. As always, you know, the emails come in. What CBD should I be doing? Well, start with the free stuff, the free quality stuff out there, and then work your way up the list. But that's a great opportunity if you want to engage a little bit more with kind of evidence-informed practice and see what's out there. So that'd be great. So thank you two very much for joining us.
Well, thank you.
If people want to follow you, let's have a little look. I think you're both pretty sensible on social media. Claire Robertson is just at Claire Patella everywhere. It's lovely. Very nice. And then Claire Minshull on Twitter. You're Claire_Minshull. That's Twitter since 2012. And then Get Back to Sport on Instagram. Get Back to Sport on Instagram. So I recommend, listeners, that you follow them. Some great information being put out there. And if you are going to Therapy Expo, then check out Claire Minshull's presentations there. It could be 3 by the time you hear this podcast. Little bird told me, but definitely check those out. And I don't know, Claire Robertson, are you going to kind of mosey on down to Therapy Expo and have a little Chardonnay somewhere?
I might just do that. Yeah, heckle.
Nice.
I might
tear it up.
Yeah, just heckle. That'd be nice, wouldn't it? Yeah. Fantastic. Right. So thanks everyone for joining us. Gary Benson has I'm pleased that he's shown me that people were able to watch this episode and listen to the live lounge. Gary says, you've covered the questions I might have asked, Matt. Thanks to both Claires for sharing their time, knowledge and expertise with the STA and wider industry. Good to catch up, Claire, sometime. Fantastic. Thanks, Gary. I'm worried that you all disappeared. We will be back next week. If you listen to the podcast and you want to come along to the live lounge and ask questions and hang out here, next week in episode 166, we're going to start bringing you speakers from the ST Update Theatre this year at Therapy Expo. So my special guest will be Dr. Lucy Williamson, who's opening the show on the Wednesday with her presentation, Personalised Nutrition for the Future, the Gut Microbiome. It's thanks to Lucy Williamson, I realised that I've developed age-related lactose intolerance. I've stopped drinking milk and it's made a huge change. Yeah, absolutely incredible. Yeah. It's fantastic. I'm really pleased about that. So if you're interested in nutrition, then definitely that would be one. Come next week to have a listen. But that's going to be opening up the STA Theatre on day 1 at 9:15 a.m. If you're interested in that, then go along to the website lwnutrition.co.uk. Right then, that's it, people. Claire's, if you could just hang around for a second, don't press any buttons, so I can say thank you personally. But everyone else in the live lounge, thanks for joining us. Glenn Murphy again, thanks for hanging around and Thank you for your comments. Great chat, says Glenn. Sarah Jones, great chat. Thank you very much. And everyone else who joined us in the live lounge, thank you. Hopefully we shall see some of you next Tuesday. Thanks again to my guests, Claire Minshull and Caire Robertson.
Thank you.
you.
Bye.